Diabetes is one of the strongest risk factors for coronary disease, so it's very common for us to see diabetics in the cath lab. Grossly, around 1/3, 1/4 to 1/3 of the patients in the cath lab have diabetes. And that's increasing all over the world. And that's in our cath lab. In some other regions, sometimes half of the patients have diabetes, and it's increasing. Diabetes per se is a risk factor for reestenosis. But on top of that, diabetes is also associated with small vessels and with long and diffuse disease. Those are also risk factors for reestenosis. So the chances of having reestenosis is higher if you have diabetes. That's problem number one. And problem number two is that once you have reestenosis, and if you have diabetes, the chances of reestenosis are higher, and also the treatment of the reestenosis in patients with small vessels, and diabetes have more small vessel disease, the treatment of a reestenosis in a small vessel is more complicated than the reestenosis in larger vessels, because then you will have to do an intervention or a reintervention in something which is small. With drug-coating balloon nowadays, you don't see any signal of safety issues, mainly because we know better how to do angioplasty now. That's number one. And number two, if something occurs, you may end up having a stent which is readily available. It varies from cohort to cohort, but on average, you will need to implant a stent. If you try to do the CB, you will end up having to implant 1 or 2 stents in 10 to 20% of the cases. So in 80%, at least 80% of and that's fine. There is no safety there. You don't have more complications if you are trying to do a DCB. And you end up having only DCB as the main treatment of the patient in 80% of the patients. So that's safety. In terms of long-term results, reestenosis arise, and then you have to compare the rate of reestenosis of DCB versus DES, regulating stents. And when it comes to some subjects, it seems that the rate of reestenosis, the risk of reestenosis after DCB is at least the same of DES with some subjects. There are some data coming showing that in diabetics, DCB may perform even better than drug-eluting stents. Those are studies that are coming. You have to be cautious with the interpretation of sub-studies. And in these studies, the diabetic population is one of the subgroups, but the signal is there, and it's very clear. DCB for diabetics are at least as safe and as effective as DES, if not better. This is where we need evidence. You cannot compare devices without measuring the performance of those devices. We don't have many studies head-to-head comparing DCB versus DCB2, but those studies that are now coming to our knowledge show that there may not be a class effect between DCBA and DCB2. What we see is a difference, especially in terms of performance in the long run, brain stenosis, the need for repeat revascularization, in favor of those DCBs that have been around for some time as compared to new DCB. Of course, this is an open question, and hopefully new DCBs will have performance as good as others. But as we see right now, there's not any signal that there's going to be a class effect there. The Cyclone Please and now the Cyclone Please Neo is one of the oldest, if not the oldest, DCBs being around, and its efficacy and safety has been proven in so many trials that it is very often regarded as the standard against which other DCBs will be compared to.